Thank you very much for joining us here today for a very interesting discussion and very timely given the changing of the seasons. Before we proceed, I would like to acknowledge on behalf of the University of Waterloo that we live and work on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. The University of Waterloo is situated on the Haldimand Tract, the land promised to the Six Nations that includes 6 kilometers on either side of the Grand River. So most of you know me, but for those of you who don't, I am Charmaine Dean. I'm the Vice President, Research and International at the University of Waterloo. A pleasure for me to have you all here today to consider a very interesting and important topic. On behalf of the Office of Research, I welcome you all to Research Talks, and in particular, I welcome our panelists here today. Today's session is about boosting vaccine uptake. It's going to include a panel presentation and a discussion examining the barriers and the strategies associated with vaccination programs. We're going to have each of our speakers give a short presentation presenting their views on the topic, and then subsequent to that, we will have a panel discussion, an opportunity for question and answer with the audience. I'm going to start by introducing all 4 speakers simultaneously on our panel. And I'll ask that as I introduce the speakers, if you would be kind enough to stand so everyone can see you. Heather McDougall is an associate professor of history at the university. She specializes in Canadian history. She's an award-winning author and expert on the history of medicine, public health, and health policy. Since publishing Activists and Advocates, Toronto Health Department, 1983, in 1990, her research has examined, 1883 to 1983 and 1990. Her research has examined Canada's response to outbreaks, including the 1918 flu pandemic, and how this historical event compares to current day events like avian flu outbreaks or SARS. Her current Canadian Institute of Health Research funded project examines the public and professional reactions to the measles vaccines and related immunization campaigns that were rolled out from 1963 to 2018. Through this historical study, Heather investigates how declining trust in experts, popular understanding of risk, and the re-emergence of anti-vaccination discussions have impacted vaccine uptake. You're welcome to sit. Heather is also working with public health agencies in both Ontario and Quebec to determine which historical factors have influenced public support, opposition, ambivalence to immunization campaigns. She received a bachelor's degree, a master's degree, and a PhD in history from the University of Toronto. She is a long-standing member of the Canadian Society for the History of Medicine. Nancy Waite is professor and associate director of clinical education at the School of Pharmacy and director of the academic leadership program at Waterloo. Nancy's research explores the impact of pharmacists' scope of practice changes on health outcomes, with a focus on pharmacists as immunizers. She has over 20 years' experience as a pharmacist, as an educator, and a researcher in Canada and the United States, and has received national awards for her contributions to education and research. She's a co-founder of the Ontario Pharmacy Evidence Network, a collaborative research program that fosters innovation in pharmacy practice and evaluates the effectiveness of Ontario pharmacist-led medication management programs. She received a PharmD in pharmacy from Wayne State University and a bachelor's degree in pharmacy from the University of Toronto. Edward Toms is director in the Vaccine Epidemiology and Modeling Group of Sanofi Pasteur, North America. He's an adjunct professor in the Department of Mathematics and Statistics at the University of Guelph and York University, and is a member of the Waterloo Institute for Complexity and Innovation. His primary areas of research include biomathematics, epidemiology, data science. He works with vaccine epidemiology and modeling groups to quantify vaccination drivers and barriers, and to develop optimal disease control strategies that consider the burden of infectious disease, current vaccine dispersal and success, and the potential future outcomes of vaccines. He received a PhD in astrophysics from Queen's University and a bachelor's degree in science with a specialization in physics from the University of Alberta. Natasha Crowcroft is a doctor of medicine and professor in laboratory medicine and pathobiology at the Daniel Lanner School of Health in Public Health at the University of Toronto. She's also an adjunct scientist at ISIS and senior fellow at Massey College. Is that still the name to pronounce it? No. She has more than 25 years' experience in public health, both nationally and internationally, and over 2 decades of senior leadership experience in infectious disease surveillance, infectious disease prevention, control, and outbreak response. In 2007, she was recruited to be part of the leadership group at Public Health Ontario, responsible for rebuilding the public health system post-SARS. Her most recent role at Public Health Ontario was Chief Science Officer. In June, she launched the Centre for Vaccine Preventable Diseases at the University of Toronto, and she is the inaugural director. Natasha has published over 250 peer-reviewed papers with research that aim to maximize the benefits of immunization. She provides expertise for the World Health Organization. She co-chairs the Canadian Association for Immunization Research, Evaluation, and Education, and she is a long-standing member of the Canadian Immunization Research Network. Natasha received a Doctor of Medicine from the University of Cambridge, a Master of Science in Public Health, and a Bachelor of Medicine and Surgery from the University of London. It's such a pleasure to have you all here today to discuss this very interesting topic. I will also mention right away that we have our Associate Vice President, Interdisciplinary Research, Bernie Dunker, here with us today, and Bernie will chair the question and answer section at the end of this panel discussion. So to begin, each of our panelists will give a short talk, and then we'll move to the panel section.
Thank you, Dr. Dean, for that very kind introduction. I'm not normally that much of a center shot, folks, but I guess the surprise of being the only artsy presenting today led to all of that. I am going to give you a very, very succinct overview of a rather important issue, which is vaccine hesitancy. And it turned out to be the unnamed development in all the research that I've done on the history of the measles and the MMR vaccine since it was introduced in the 1960s. As you are all well aware, in February of this year, the World Health Organization identified vaccine hesitancy because of the resurgence of measles and various other ailments around the world as one of the top 10 threats to human health. It had established a working group that reported in 2015 and defined vaccine hesitancy as a range of actions from partial acceptance to refusal of specific vaccines, generally based on 3 factors: complacency, convenience, and confidence. As a historian, my initial reaction to all of this was, okay, so what's new? Because basically, if you break down each one of these terms and look at it historically in the Canadian context, what you become aware of is that all of this has existed. It simply wasn't named until the beginning of this century. Modern immunization campaigns, specifically for the polio and the measles vaccines, started in the 1960s, and initially there was tremendous uptake. But by the middle of the 1970s, Canadian experts were already blaming the lack of uptake on parental apathy. This wasn't actually totally true. Women were joining the workforce in large numbers. It was much less convenient to try and arrange immunization. And as we'll see when we look at convenience, there were some systemic issues as well. By the end of the 1970s, because the Americans had decided they would eradicate measles, New Brunswick, Ontario, and Manitoba all decided they would follow suit by creating legislation that required proof of immunization for measles and, in Ontario's case, 5 other diseases for school entry. What is really interesting in the Canadian context is that none of the other provinces and territories actually adopted this model. Instead, they relied on the traditional response from science, which was health education. If we give them the facts, the data, they will understand, they will change their minds, and as long as we have the Canadian Pediatric Society and the Canadian Public Health Association providing health education material, we will maintain parental interest and engagement, and hopefully that way increase vaccine uptake. I should point out that the other provinces that do not have the immunization of school pupils legislation have roughly the same high level of immunization as Ontario. So, convenience. One of the unspoken factors that we discovered in the research, I do this with a colleague at the University of Montreal, Laurence Monet, to compare Ontario and Quebec basically, but look at the rest of the country as well, is that the implementation of Medicare at the provincial level in the 1970s raised a lot of questions because although the federal government ostensibly has all the money, the provinces have all the responsibility for the delivery of health services. And that includes immunization. So that brought up a very, very crucial question, which is still an issue in the present. Who should provide it? Should provinces rely on their general practitioners and pediatricians fundamentally to ensure childhood immunization, or would they be better off turning it over to the public health nurses? Alberta and British Columbia, which predominantly use public health nurses, particularly in rural and remote areas, have very high and ongoing rates of immunization. Ontario and Quebec opted to have a mixed system of doctors and public health nurses in some instances. This has been somewhat less successful in ensuring absolute coverage and preventing vaccine wastage. So, that then brought up the whole question of how do we know whether coverage rates are actually what we would like them to be, let alone what they should be. This country does not have a national vaccine immunization schedule, and it doesn't have a national registry. Very gradually through the 70s, 80s, and 90s, the demands for this arose, and ultimately, we also got a call for a national immunization strategy. Initially, it started on a disease-to-disease basis. Measles was first. There was a plan by 1986. It crashed and burned because of opposition from the provinces. The other important systemic problem in terms of convenience was immunization for Indigenous, rural, and remote groups, and of course for the religious groups which prohibit immunization in their congregations. And so obviously then, this is not a simple one-size-fits-all issue. It does not have simple solutions. It took basically until the researchers and practitioners managed to persuade the federal government, courtesy in part of the Romano Royal Commission in 2002, that we should have a national immunization strategy. So history is important because it provides the context and the understanding as to why we seem so slow and so far behind the American model in achieving change. And finally, confidence. Confidence is, of course, crucial. We are asking the public, parents, to accept immunization for their children and themselves, to take on trust that these are safe and efficacious vaccines that will protect them from specific diseases. one of the real ironies in the research that I've done is the discovery that it was Ontario's immunization of school pupils legislation that reanimated what was at that point a dormant anti-vaccination movement. And it did this on two different and very important levels. First of all, through the 1960s and beyond, we've had second wave feminism, and I understand we're now into third wave feminism. And part of feminism was, of course, questioning of patriarchal authority. And for a lot of well-educated, upper middle class women, the ultimate in patriarchal authority is their family doctor, if in fact their family doctor is still male. And so through the 70s, 80s, and 90s, we get questioning by these women of the benefits of vaccination to them and their families, given that measles, chickenpox, mumps, rubella, and the various other childhood immunization diseases don't appear to be widespread in Canada or North America. As we're all aware, of course, that is not the case in other parts of the world, and therefore you need to maintain community immunity in order to ensure protection for children and any immunocompromised individuals. So the feminist critique then is highly understandable, but has had very important consequences in the past and into the present. Environmental concerns may sound a little bit more far-fetched, but in 1962, when Rachel Carson published Silent Spring, that was the point at which the burgeoning environmental movement really took off. And in the questioning 1960s, you had the development of communities in central and western Canada which questioned whether immunization was legitimate because it was putting a foreign substance into a pure infant body. That, of course, creates another strand of criticism of immunization. The Committee Against Compulsory Vaccination that emerged in the province of Ontario gradually became the Vaccine Resistance Awareness Network. And it was very closely tied to the American anti-vaccination movement. But underpinning all of this, and I think a factor in the creation of the vaccine hesitant who exists today, was the switch from collective healthcare, as exemplified by the implementation of the Medicare system, to health promotion and personal responsibility for your health. The middle-class women and upper-class women that I've been talking about took this very, very seriously. They'd been university trained. They'd had jobs. Now their children were their jobs, and they were going to research and look into this. And of course, once they found the anti-vaccination information, then they had to really question whether it was the right decision to immunize their children. The emergence of the internet in the mid-1990s, of course, has amplified the spread of misinformation, and I think it contributed, unfortunately, to a factor that had been evident all the way through the period that we've been examining, and that is the gradual erosion of trust in experts, in science, in medicine, and of course in government. So, you're all going to have to read the book when it comes out to understand the deep social and cultural roots of vaccine hesitancy, because they are what is going to make it very challenging to develop effective responses to the people in the present. Thank you. And Nancy Waite is next.
Thanks very much for the invitation to speak today. Very excited to share the research that we've been doing, trying to understand whether the Ontario pharmacists that are now able to immunize have given a shot in the arm to influenza immunization delivery here in the province. And I'm going to share with you a very quick snapshot of the research that we've done over the last 7 years. A quick declaration for funding. The Government of Ontario funded all the research that you're going to hear today, but I also do receive funding from Sanofi, Pasteur, GlaxoSmithKline, and Merck Canada. Why do we even consider pharmacists getting into the business of influenza immunization? And it had a lot to do with the numbers, so let's start with those. About a third of individuals at that time were immunized against influenza. We saw that of those that weren't vaccinated, about 1 in 5 would get the flu. The consequences of getting the flu, I don't know, did anybody hear me on CBC radio this morning? The only thing they quoted me about was that it sucks. But anyhow, that was a word that was used frequently and recently to me, and I do think it sums it up. It's 2 weeks of being sick, 7 to 14 days of feeling really, if you've had the flu, it's one of the best ways of convincing people to get the flu vaccine, unfortunately. So it isn't just a cold. It is certainly a serious illness in terms of how it affects you. But it also causes a lot of other complications, hospitalizations, and it is still one of the top 10 causes of death here in Canada. So a very significant illness. We have a vaccine that is quite effective in terms of protecting against it, and yet many of us were not vaccinated. The other thing that came out, though, is we talked to people, and this has been shown in many different studies, is we asked people, if a healthcare professional recommended the vaccine, would you get vaccinated? And 70–80% said, yeah, I get vaccinated. Just nobody's told me I need the flu vaccine. So we began talking about what other healthcare professionals could be involved in trying to get the vaccine to more people, and also talking about that convenience factor, that for many of us, and I'll count myself as one, to get my 2 children, my husband, myself, all together on a schedule that I could find so we could get to that public health clinic or get an appointment at 2 or 3 different physician offices to get our flu vaccine was challenging. And so pharmacists were brought in as a potential opportunity, certainly trusted in terms of polls. We're always 1 or 2, which is very nice. Very accessible. You can see your pharmacy in the grocery store, Costco, and even in small communities, most of them will have a pharmacy. They also have extended hours, and so many are 24 hours now. Down in the States, they have drive-through influenza vaccination windows. We haven't quite got to that in Canada, but ultimate inconvenience. You do have to go park for a few minutes afterwards, just so you know, and no appointments were necessary. And so this was felt, and I don't know how many of you have been vaccinated at a pharmacy, but I can tell you 2 occasions. The one was my university-age son. I asked him if he was vaccinated, he got the flu vaccine. He says, no. I was driving by a Shoppers. I did a U-turn. We went back in. I said, would you like to get vaccinated now? He said, sure. It's so convenient. You can decide at the spur of the moment, just walk and get it done. So if I had shown you this chart in 2010, so not that long ago, it would have all been red because pharmacists were not providing any immunizations in any of our provinces. So what you can see now is across the top of the different provinces and territories, down the side are all the different vaccines, and you'll see that in majority of provinces we can give a good portion of the vaccines. Not as many, it's not childhood vaccines, so that's one space that we, at this time, are really not quite as involved in. And most provinces started with the influenza vaccine. 2011, BC was the first to offer pharmacists this opportunity, and 2012, Ontario. And then after we had some success with that for a few years, then the other vaccines were added in. And one thing that where we're at now is that pharmacists are actually the leading vaccinator for influenza in Canada. So, of course, back then we didn't know that was what was going to happen. We didn't know what would happen when we initiated this. So 2013, we were beginning to think about our research questions. We wanted to know what was the impact we were going to have on immunization coverage, on healthcare costs, on satisfaction with the service, what was happening to the pharmacists as they were introducing this into their environment, and were we addressing that vaccine hesitancy that we knew was out there. We used all kinds of research methods, not going to begin to go into this, just to say everything from, you're going to see today, some very large administrative database work to interviewing qualitative work and everything in between. So this is an early chart that we did, taking a look at the number of people who were vaccinated by physicians, which is in the light gray, and then you'll see in the last 2 is the pharmacists' added immunizations. And you can see sort of over the last 10 years, we sort of had this decline in where we were going with immunizations. And so we were really pleased to begin to see sort of this uptick as soon as pharmacists were vaccinating. This, though, is not the only way you can get vaccinated. You can get vaccinated workplaces, public health units, et cetera. So we pulled all that data in as well. And we saw that at that time, there was actually a net increase of about 500,000 patients that were now vaccinated that were not vaccinated before here in Ontario. At that time, we were giving about 750,000 doses. We are now, every year in Ontario, pharmacists are giving about 1.2 million doses, so I would expect that that number is probably more. We just have not been able to do the research for some other logistical reasons. The other way we wanted to take a look at this in terms of are we impacting uptake was we took a look at the Canadian Community Health Survey, and there's a question there that asked, did you get the flu vaccine last season? And then we took a look at, as the provinces introduced this legislation, what happened to those rates. And what we found was, in provinces with pharmacists as immunizer policies, there was a 5% increase in vaccine uptake in those provinces. So it appeared to be effective. I would also argue, though, that that was a modest increase. I really would love to have seen a really nice bump, but at least it was in the right direction. And certainly we were beginning to counter that downward trend. The other question we had then is, well, who are we vaccinating? Are we vaccinating the same people? So the other very large group in Ontario, physicians still immunize more patients than pharmacists do in Ontario. That's actually not the same as I've just mentioned in other provinces. So, but we want to understand who's coming into our offices. So if they're seeing Natasha, is that different than who was seeing me in the pharmacy? And so what we found when we took a look at about 3 million patients, that pharmacists were more likely to vaccinate those individuals who were between 20 and 65, so probably everybody in this room, and a little bit of a higher income group, and certainly sort of that mid-flu season when we all sit there and say, oh my gosh, it's November, we have to get vaccinated. Physicians were more likely to vaccinate those children and seniors, those with chronic diseases, immigrants, et cetera. So probably individuals who were most comfortable going into physician offices already and were probably used to getting their flu vaccine there. And they vaccinated a little bit more very early in the season, often because they had the flu vaccine available to them. So we took a look at this and said, is this good? You know, this is probably a lower risk group, that 20 to 65, although certainly many have chronic diseases in that age group as well. And one of the things that we commented on is that they're a hard to reach group because they're the people in the room. You're sitting here, you're not trying to get a doctor's appointment and so on. So we do think that a lot of this has to do with accessibility and the convenience. The other really important part about vaccinating this group, though, is that they're caregivers. So who are the caregivers for? The high-risk individuals. So either very young children or seniors, the sandwich generation. So this is good to see that we can reach that group. And I think that also has really opened up why we've had some of the other vaccines added, is that we're able to reach a group that really does need to be vaccinated. So my question then was, if I know who we're vaccinating, who are we not vaccinating, or why are we not reaching certain groups? So we went and stood in pharmacies and asked people to complete a survey if they were in the pharmacy, so they could make it to a pharmacy, but that they had not been vaccinated by a pharmacist. And we asked them some questions about why had they not been vaccinated. A third of them said, I don't know, that pharmacists could do that, so certainly we still have some work to do in that space, although I think that probably has changed over the last few years. Why was that? Why did they not get vaccinated? Because they were used to getting it elsewhere. But I want to point out that red bar, I don't want or I don't need the flu shot. So that vaccine hesitancy is probably still one of the reasons why people aren't getting vaccinated, whether it's a pharmacist, a physician, or whoever. We also asked them, is there anything we could do to increase your willingness to get vaccinated? And I think this was important because this is a new space for us to be doing something like giving a needle. And so people still, that convenience, shorter wait times, don't make me wait if I'm coming in, make sure it's flexible, but in more private space. So recognizing that pharmacy has now moved into a different clinical space, and we need to think about that space differently and make sure that we are meeting our patients' needs. The other question we had then is, are we dealing with that vaccine hesitancy question? Are we answering people's questions? Are they coming to us? So we did some survey and interview work and asked them just that. And pharmacists said to us, we see vaccine hesitant patients all the time. This is part of our regular practice. We're very knowledgeable and confident about answering questions. We actually tested them on that, and they were indeed knowledgeable. And yet, they said, when we probed a little further, they said, but we actually don't talk to people about vaccine hesitancy that much. So we went, whoa, that's not what we were expecting. And their comments were, first of all, that they tended to see vaccine hesitancy as a binomial. You're either an anti-vaxxer, so you're not going to get vaccinated, or you're a vaccine acceptor. And so their concern then was, I don't have time to get into a conversation with somebody who is very anti-vax because it's very busy practice. So I tend not to enter into these conversations. And the other thing was that 70% of the patients who came to them about vaccine were actually already ready to get their vaccine. So they were not being approached by a lot of patients, although certainly 30% still had some questions, and they were able to address it with those patients. But our comment here would be that this is very much a missed opportunity for pharmacy and something that we need to work on. And finally, they were really not familiar with the strategies that are out there in terms of being able to address vaccine hesitancy issues. I actually forgot to say at the very beginning of the slide that this work has all been done by my PhD student, Gokul, who is here today. And I just want to give a big shout out to the students who sit there and think through this work and really bring so much to the questions that we ask and how they get answered. So thank you. The last thing I just want to comment on then is if they're really not answering as much about this vaccine hesitancy as we would like, why is that? And we heard fairly loud and clear, the very bottom red circle there is that it's just too busy. And I think that one thing that maybe we forgot a bit when we introduce a new service into a space, so this is now a pharmacist who may not have been involved too much in even touching patients, let alone giving an immunization. How does that actually operationalize in that pharmacy? And so their comments is that the existing pharmacy staffing, the workflow and so on really didn't catch up with how this was to be run. Just a quick comment, it was announced in like May and we were already implementing in October. So it was a very fast turnaround as well. So now we're doing research with pharmacies in terms of change management and how they can manage their practice better so they can be more engaged with patients in vaccine hesitancy, but also outreach to those higher risk patients who are seniors and so on, who are in their pharmacy getting prescriptions, et cetera, as well. So thank you very much. It's a quick overview of the work that we've been doing, and I'll be glad to answer questions as we move to our panel discussion later. Thank you.
Well, thank you very much for the opportunity to speak here, and thank you for being here. So I am, well, I guess this constitutes my disclosure simultaneously because I don't have a separate slide for that. I work for Sanofi Pasteur, which is a pharmaceutical company that makes vaccines. Specifically, I work for a group there called the Vaccine Epidemiology and Modeling Group. And what do they do? Well, the short answer is pretty much what it says on the can. The slightly longer, but not too long answer is what I'm going to try and give you. I'm going to try and give you a sort of a quick overview, a grab bag, if you will, of the different things that we do, which all intersect in some form or other, directly or indirectly, with questions of, vaccine uptake, effectiveness of vaccines, ways in which, vaccines may be used more effectively in the future. So again, this team is kind of spread across all over the world. The headquarters is in Lyon, France, as indeed is the headquarters of Sanofi Pasteur, but there are members in Canada, in the US, and all around the world. And the slightly longer answer to what we do, and I'm going to try and quickly throw up an example or two of each of these. One thing that we do is these so-called real-world evidence studies. Now, of course, we know that the gold standard for figuring out how well a drug or a vaccine does is to run an actual clinical trial. Now, you can't, if you want to look at how well these, say a vaccine does once you release it into the real world, you are in the realm of doing one of these so-called real-world evidence studies. The problem there, of course, is you're not dealing with a randomized controlled trial, so a lot of things become much more complicated. It's a much messier study. You have to worry about lots and lots of sources of confounding. So that's one thing that we work on. On the modeling side, so we do a fair bit of biomathematical modeling of infectious disease. I mean, the very simplest estimate that you can make is if you have a vaccine that has an efficacy of, say, 70%, you ask the question, what would happen if you gave this vaccine to people? The zeroth order estimate that you could make as well, the level of the disease, the prevalence of the disease will be reduced by 70%. Now, it's not quite that simple because there are, for instance, you may have heard of herd immunity or herd effect, which also kicks in when you have infectious disease and vaccination. So when you want to study these things in more detail, you have to resort to more sophisticated and complex modeling. The other thing which I think maybe intersects most directly to what we're talking about here is understanding vaccination behavior of the population at large. So drivers of vaccination and barriers to vaccination. Some sort of more, I guess if you wanted to use the technical term, pointy-headed biostatistics, also stuff that we work on. Again, you know, when you worry about confounding and establishing causality of things, there's a fair bit of mathematical machinery there that you can either try to use or maybe even improve on. We do health economic evaluations of vaccines, so how much does it, you know, what's the payoff essentially of introducing a new vaccine, which may do more against the disease that you're targeting it at, but also, I mean, generally newer vaccines cost more. So then the question is, how much does the one offset the other? And in all of this, we collaborate quite a bit externally with academics, with public health, with vaccine advocacy groups, and so forth. So a big part of what we do are these sorts of external collaborations, external partnerships, because I mean, in the end, if you have a pharmaceutical company telling you, well, you know, here's why you should vaccinate, I mean, for a good cause, that has limited traction, perhaps. So a couple, I'll quickly try and plow through a couple of specific examples. So on the side of real-world studies, here's something that just recently came out that we did with the U.S. Department of Veterans Affairs. The nice thing there is they have detailed data on detailed records on their patients. So we looked at, we did a vaccine effectiveness study of standard vaccine, standard dose vaccine versus an elderly specific variant called high dose vaccine, which has quadruple the dosage because elderly immune systems generally need a little bit more of a kick. The challenge here was, as we found out, that there was systematic differences between the populations that were getting the normal vaccine and the high-dose vaccine. So with a limited amount of vaccine available, sicker, frailer patients seemed to be getting prioritized for the vaccine. So you had to account for this source of confounding where you weren't kind of having the two different arms of your studies properly balanced. On the side of biomathematical modeling, here's a publication on a dengue fever model that was worked on by one of the people in heading our group, Laurent Coudeville. And you know, this is, as far as biomath models go, this is a fairly complex version because you have not only people transmitting amongst each other, you have the vectors, the mosquitoes that are transmitting disease. Some other modeling work that we're doing in collaboration with York University and other people elsewhere, and a group called Immunization back in France, is to try and fit mathematical models to influenza surveillance data, which is, of course, notoriously difficult to do because it's very noisy data. There's a large amount of underreporting. You only ever capture the tip of the iceberg. I mean, you don't laboratory test every person that you think has the flu. And the even more ambitious goal eventually here is to do something that a lot of people have tried to do with varying degrees of success, which is to try and actually predict the flu season ahead of time to some degree. Hope hopefully enough and meaningfully and accurately enough that it can actually have some impact in various different ways. It can help with, if you do this right, it can help hospitals with capacity planning. It can maybe help with optimal vaccine distribution. And if this is information that ultimately you're able to put in front of the public at large, I mean, the same way that we look at Google Maps and we say, oh, there's bad traffic here, maybe I'll reroute myself. If you're told through a reasonably credible forecast that flu is going to hit where you are fairly hard, say 3 weeks from now, it may be that extra push that makes a person decide, well, maybe I should make a little bit of time and head down to the pharmacy. You're probably not going to convince a committed anti-vaccinator, but of course, lots of us, as we've been hearing, are, we're influenced by convenience and just not having enough time. What's this one? This is, again, some work that was just published on a sort of a literature review of other work that has been done on determinants of vaccination, barriers and drivers of vaccination. One of the things that we found here and are finding in work that we're currently doing is, depressingly but not surprisingly, there's a strong component of socioeconomics and race and ethnicity in how equitably or not equitably vaccines are administered, in particular flu vaccine. I think maybe I'll skip over this. This is on the side of the pointy-headed biostatistics. This is something that's going to come out in statistics in medicine, but and this is an example of some cost-effectiveness work that we've done, again involving high-dose vaccine and kind of piggybacking on top of the clinical trial, kind of attaching dollar signs to everything and asking the question, this is before the vaccine was used in the general population, how much benefit would you get from this in return for paying more money for the vaccine? In this case, the answer was, what as a health economist you always hope to see, which is that it would actually be cost saving. And just to put this up for a moment, this is this collaboration with York University that I alluded to before. They actually have there's actually an NSERC industrial research chair that's endowed there. And the PI has this group called the Laboratory for Industrial and Applied Mathematics, or LIAM, and much like Liam Neeson, they have a particular set of skills. Actually, I wonder if that's why they picked the acronym. I never thought of that. But anyway, so this is an industrial research chair that's co-sponsored by us, by Sanofi Pasteur, by NSERC, and by York University. And so we're working on a whole bunch of different projects with them. And I will stop with that and look forward to getting your questions soon. Thank you.
Thanks very much.
So hi, everyone. So before I start, I just want to ask you a question. Can you put your hands up if you died from a vaccine-preventable disease when you were a child? Anyone? Okay, nobody put their hands up, which is kind of reassuring. I'd be a bit worried if you did. This is an example, I guess, of what's sometimes called the availability heuristic, that we are not aware of things we don't hear about, but we are aware about things we do hear about. And what we hear about is all the problems with vaccines and not the problems with the diseases because they've gone away. So we've just heard from 3 excellent speakers, a whole bunch of issues about immunization, about the complexity of the problem of convincing people to get vaccines, about the complexity of changing anything in this complex healthcare system that we have, and knowing about what's happened when you do change something as well, and about some of the pointy-headed science, so the science isn't necessarily simple either, which makes it hard to communicate to parents. So it's not an easy problem. And that's one of the reasons that we have set up a Centre for Vaccine Preventable Diseases at the University of Toronto. It's a public health led centre, And it's the first public health-led centre in Canada, and it's the only centre for vaccine-preventable diseases or centre focused on immunisation currently in Ontario. And it's a very collaborative centre, so I'm very pleased to work with all sorts of people, including my esteemed colleagues here. So, so what I want to talk about is, in relation to dealing with vaccine hesitancy, the problem is what our priorities are for this centre and what we've chosen to do, because it's directly relevant. And the issue of vaccine hesitancy is really focused on how do you reach parents? How do you convince parents? And that's not an easy thing to do if parents have made up their minds. We all think we know, we all think we're right about everything, and everything we assemble from the world around us just keeps on convincing us that we were right, whatever it is we were thinking. So how to reach parents, and the numbers that are kind of concerning is that more than half of parents in this Canadian survey were concerned that newer vaccines are not as safe as vaccines, the older vaccines, and that they're more concerned about the safety of vaccines than they used to be. And this is starkly, this is a really good stark example of how parents are wrong, because these vaccines that are being used, the newer vaccines, all the evidence points to them getting safer and safer, and yet people are getting more and more worried. So, what can we do about this? So the science is telling us that vaccines are safe, that they work, and that they're needed. But unfortunately, science is not enough. It doesn't convince people. I'm sure it convinces you guys. You're sitting in the University of Waterloo. I'll present data on MMR and autism and the fact that MMR vaccine does not cause autism, and you'll be convinced. But if you think there's a risk of autism from a vaccine and you're a parent, then having a scientific paper presented to you is not going to convince you. The other issue we're facing, on the left here is a pile of materials were sent to me by a retired public health nurse that are all anti-vaccine. There's a whole bunch of information, including a book that comes up quite high on Amazon if you do a search for information about immunization. So a book on critical vaccine studies. Like, as a parent, how on earth do you tell whether that is a genuine publication that has real information in it? Because it looks just like anything else you might find. If you look in Amazon, in fact, I think the top 60 or 70 books that appear there are all anti-vaccine, but it's almost impossible to tell. If you've heard of the organization Vaccine Choice Canada, which has a beautiful website, it's very convincing, it sounds terribly scientific, and it's vehemently anti-vaccine. So it's really, really hard. On the other side is, this is a big wall that was outside the cancer hospital on University Avenue in downtown Toronto. So it's outside a cancer hospital. And on this wall, as I was walking to work one day, I saw this graffiti, I've just enlarged it here, saying vaccines kill. So it's kind of depressing to see that outside a cancer hospital, especially, when you think hepatitis B causes cancer. We have HPV vaccine and hepatitis B vaccine both prevent cancer. They're both anti-cancer vaccines, and here we have this graffiti. The thing that was really nice is that someone else has written underneath viruses, which I think, just shows for everyone who's got an opinion, there's someone who's got a different opinion out there somewhere. So that gave me a bit of hope. But a long time ago, I did used to think that the issue with anti-vaccination sentiment was to try and educate parents. And that's what I used to think, but I know that isn't the answer now. Here is a paper, it's actually from 1996, but I think it illustrates very well the problem. So in this study, they took groups of convinced non-vaccinators and vaccinators, and they gave them information about how dangerous whooping cough vaccine is, the disease, and asked them at the end of giving this information how committed were the different groups to vaccinating. And essentially what this information did was it convinced both the non-vaccinators and the vaccinators that the whooping cough vaccine was dangerous, and it convinced the vaccinators that the disease was dangerous, but not the non-vaccinators. And it entrenched both groups in their existing view. So bottom line, basically, if they were non-vaccinators, they became more anti-vaccine, and if they were vaccinators, they became more pro-vaccine. But the impact on the vaccinators was to make them basically more worried about the vaccine. So it really didn't have the impact. It certainly didn't have a positive impact in the people who are anti-vaccine. So we have to be really careful about education because it's not always beneficial. I shouldn't really say that in a university, but, you know, education can be harmful. So what do we do? Where do Canadian parents go for information, and who do they trust, most importantly? And the most reliable and trustworthy source of information on vaccines in this survey, and I don't think pharmacists are included in that, so I'm not leaving them out, but it was the physician, the person's physician. That was who they trusted. So let's forget about immunizing parents. Let's think about how do we get physicians into a better position, and pharmacists, vaccinators in a better position to work with parents more effectively. And that's really where I think we need to go. But because we can actually also do harm this way, we also need to evaluate this really well. This has been studied, there's been systematic review of what's happening with healthcare providers and how they're dealing with this issue. And the findings echo exactly what Nancy was saying about pharmacists. Healthcare providers, they're really stretched. They have time constraints and they don't have enough information, and they often haven't had the training they need to really deal with the issue. So there's lots of things we know healthcare providers can do. The things on the top of this in sort of bluey color are more attitudinal, like be presumptive means if somebody comes in to the surgery, say, great, you've come in for your child's immunizations, let's get on with it. Like you assume that the child is going to be vaccinated. You don't say, well, how do you feel about immunization? Are you okay with it? Because, you know, you're just inviting doubt. You're confident and you believe this is the right thing to do, and that confidence will transmit to the parent. So all these things are kind of self-evident, good clinical practice, really. The ones at the bottom, following best practice on pain management, requires you to know what best guidance is on how you approach this. You know, things like don't say, this will hurt a little bit, actually makes it hurt more. You know, distraction therapy. Some of it sounds like common sense, some of it, you know, like not letting them see. Just putting up a simple board so you don't see the vaccine being drawn up helps. Because, like, I don't like looking at the needle before it goes in, and I'm not particularly worried about getting my flu shot. So, and knowing the facts. And knowing the facts is hard. The schedule keeps changing. We keep on adding to it in good ways. It's a positive thing, but it's hard to keep up. So there's having a good grasp of all the information is challenging. There are a lot of resources in Canada we can draw on. Lots of good organizations with lots of good information. But I do, you know, this book that Dr. Moore edited, Your Child's Best Shot, is absolutely fantastic. But it's 370 pages long. So yes, have it in your office as a reference guide, but the idea that anyone's going to read the whole thing and know everything in it before they meet with their patients is just not realistic. We have to find really easy, accessible tools that people can use so they have the right kinds of information really at their fingertips. You know, there's just a wealth of information, and a bit like these talks, so much information and so little time. But because of all of this, education is really the first priority of the center that I mentioned. Education and evaluation. So what we're setting up is an interdisciplinary postdoc program because it takes many disciplines to try and move forward in this. We have already piloted an immunization course for residents, which seemed to go quite well. We initially wanted a week for it. We were told no way. We went to 2 days. They said, no way can you have 2 days. We ended up with half a day. That's a stretch, but we're trying to accommodate what's realistic. And continuing medical education for any people who are immunizing. So that's going to try and really address the issue, and that is going to hopefully reach parents effectively. I leave you with this message because immunization is saving lives every minute of every day. So everyone who says anything positive about immunization, you're saving lives. I just want to tell you that right now. Everything you do to support this is a good thing. And thank you very much.
Thanks very much for the very interesting talks. This is, I guess, for anyone who wants to address it. There's a lot of information out there, as you all alluded to, and the internet, et cetera, on both sides, so the anti-vaxxers and the pro-vaxxers, I guess. Why do you think the anti-vax side seems to get so much more passion and so much more attention than the other more scientific-based side?
It's kind of easier if you're on a mission and you're trying to combat. It's like the David and Goliath story. You know, it's if you're campaigning against something you passionately believe in and you're trying to take on the system, it's so much more fun than working in government and trying to give people a balanced, dry, factual account of things. So I don't really know. I mean, I'm always astonished. I get a lot of anti-vaccine emails. And the amount of time people take to send reams and reams and things, and they keep going, it's sort of almost obsessional. Every day, something arriving. I wish we could bring that passion. Sometimes there are a few really astonishing parents who've lost a child or had a child's been affected by vaccine-preventable disease who have taken on that mantle. And I take my hat off to them because some of them have been really trolled by the anti-vaxxers in a way that's, you know, just totally inhumane. So it's challenging. You know, I haven't got a simple answer, but the good news is that all the social media groups are really taking this on now. You know, some years ago, Pinterest changed its policies, YouTube, Facebook, you know, they're all really tackling this now. And so that is really good to see. It's not going to solve everything. But I have a feeling that the climate is changing a bit and the conversations are changing. You know, a bit like that graffiti on the board. People are coming back at it and saying, no, you're not free to leave your child unvaccinated and put my child at risk. You know, that is the conversation much more than it was. Unvaccinated children are now suffering from stigma in school, which is interesting. I'm not saying that's a good thing, but it's a change, you know. It's gone from being very neutral, it's your choice, to people realizing that we really are all connected when it comes to infectious diseases. It's not, we can't act as free agents.
The only other comment I'll quickly make is that I think the pendulum is beginning to shift, and I think some of that as well is that there are a lot of people who are vaccine hesitant. I mean, probably most of us are. We have questions at times, and we want those answered, and we don't want to always hear this extreme. We want to really, we have a legitimate voice, and I think that's also been overshadowed. So I think this polarization that we have seen in politics, et cetera, as people are beginning to take control now and say, enough, I need to have a voice, I need to have my questions answered. And so I think that is becoming a bit more, I do think social media has been, the fact that they're willing to step up is really speaking for the majority of people now who want to hear what really is the legitimate answers to those questions so they can make good decisions.
So this question is for you, Dr. Thome. So I guess with all the kind of generational mistrust in things like pharmaceutical companies and the pharmaceutical industry, how can we work alongside the pharmaceutical industry as public health professionals to counter vaccine misinformation and kind of use the legacy of pharmaceutical mistrust in a productive way?
That's a very good question, and one we certainly struggle with a lot. And I mean, I think the short answer is we can't be the ones who are primarily bringing out these messages. I mean, we can partner with public health, we can partner with advocacy groups, we can, you know, try to share information in a way that's useful, but in the end, you know, for obvious and justifiable reasons, we can't be the ones mainly making these arguments. I mean, what we try to do, and especially in our group, we're part of the larger, what's called the medical division within Sanofi Pasteur. We sort of, I mean, we try to establish our credibility in whatever we do the same way that anybody else does, which, I mean, I sort of fired up a series of publications there, and really that's what we try to do. We try to do scientifically rigorous research, publish it in, you know, in peer-reviewed publications, work with, you know, the the people in the field, the smartest people in the field, the people who are doing, you know, interesting research. And of course, that's where we have no trouble finding, you know, like-minded people who also are, you know, have the same goal of increasing vaccine uptake. And you know, the sort of the overriding thing is, you know, when we do this research, you know, various things have happened in pharma in the past. I mean, nowadays, if we do research and we find a result and we maybe commercially the result is a little bit inconvenient, we still have to publish it. So we can't just throw things under the rug. And, you know, so we have to hold ourselves to a high standard, and we have to be held to a high standard. And yeah, I guess that's, you know, basically that's the best that we can do.
Thank you very much for very interesting presentations, all of you. One thing on one of the slides, and I don't remember whose slide it was, that really struck me is the fact that there is a contingent of the population that believes that new vaccines are more dangerous than old vaccines. And that puzzles me. I don't quite know how that could catch fire. But it leads me to direct a question to our colleague from Sanofi. When your objective is to make a vaccine safer, I presume that a major part of what you try to do is to reduce the non-specificity of interaction. Is that correct?
Yes. I mean, I should emphasize I'm not a clinician, but I mean,
Okay.
basically that's, yeah, I mean, there are multiple phases of these
Right.
clinical trials.
Right.
The early ones are, I mean, first and foremost, the objective is to not, you know, cause harm, cause adverse reactions.
Right, which is non-specific
Exactly,
interaction. So my real question is this. Given that we're faced with this problem, would it not be, that's an easy concept to sell, using informatics, et cetera, et cetera. There are various ways in which you could sell that and convince people that that's what the real situation is. Even parents, I would have thought. And is this part of Sanofi's strategy to try to educate people about these kinds of issues?
I mean, that's a very good point, and I think, you know, I said before there's not that much industry can say. I think you've hit on one thing that we actually can do. We can be as, you know, we can give as much information as we can about what is the actual process that goes into designing and manufacturing these vaccines, because as, you know, you may well imagine, it's an, you know, extremely complex and involved process with lots and lots of safeguards. I mean, like I said, I'm not a clinical person, but I had the chance to go on a tour of our manufacturing, the manufacturing part of our facility, and I was certainly impressed. And I had to wear, you know, the gowns, and there were different levels of clean room that you have to go through, and some you can't go into at all. So I think that's actually a really good point. The more information, and I mean, we don't have to be very proselytizing about it. If we put out information about this is what actually goes into vaccine manufacturing, this is what actually goes into making sure that there are no adverse reactions before we ever evaluate the efficacy of a vaccine, I think maybe that's one way that we can help.
You could get pamphlets, for example, that you could distribute to physicians. They could give them to
Excellent idea.
I just want to comment on why I think parents might be thinking that, though, that there is a slightly different angle on this. My interpretation is that parents probably think the vaccines they got were safe because most parents now would have been vaccinated. And so they think, oh, well, I'm fine, and I didn't hear anything about issues when I was a child. And so everything I'm hearing now must be about these new vaccines. So I'm not sure it's anything to do with information, again, or facts of any kind. As you say, it's very easy to dismiss the idea that that vaccines today are less safe than they used to be, because, you know, the polio vaccine we use now is an inactivated polio vaccine. It doesn't have any of the same risks that the live attenuated vaccine had, which parents today would have had when they were kids, probably. Same thing, the whooping cough vaccine now is a much simpler but chemical structure than the old wholesale vaccine we used to use, and has much lower rates of side effects. So the factual piece is very easy to dismiss. I think that the challenging piece is more the psychological one, that, as a child I had something that was fine because my parents thought it was okay and I'm okay. And now I'm hearing things. And so there must be something wrong with what's going on. So I'm just going back to this thing that it's not a simple model. It may be more important for your doctor to just say something really simple to you, like, and I've had this experience where, I give people a load of information about MMR vaccine, and at the end of it they say, yes, but did you have your kids vaccinated? And that's what they want to know. They want to know, do I believe? Because if I believe, they believe. They don't want to know about the facts. They want to know, if they trust me and I believe in this vaccine, they'll have it. So it's a little bit more than what's in the vaccine and what information you hand over. So I'm just giving you a different angle on it.
Thank you. Very, very interesting discussion. I'm wondering about those sitting on the fence. And there's this unscientific post-season analysis that basically said, well, that particular strain of flu in a vaccine didn't seem to work very well, and therefore why bother getting it next year? What is the science behind determining and defining what flu vaccine is going to go out? And then how do you then speak to parents to say, well, we think we got it right this year?
Okay. Well, I guess the short answer is it is a fairly complex process that I'm not going to pretend to understand in great detail. I mean, what happens is that early in the year, the WHO tells the manufacturers, these are the strains, these are the reference strains that are our best guess of what's going to happen in the coming flu season. Put these in your seasonal flu vaccine. Where that comes from is basically surveillance in the southern hemisphere of the preceding season, and looking what's going on there, and then essentially making the assumption that a lot of that stuff is going to come to the northern hemisphere in the subsequent season. So the interesting angle is, we do seem to have some sort of advanced indication of how well or less well matched the strains may be. I think the post-season surveillance, there are different ways to do this. And again, I was talking before about, biostatistical methodology. One has to be a little bit careful there. One challenge in general with vaccines is because they take a long time to manufacture, there's a lot of lead time. That's why we have to decide on the strains so early in the year. Future vaccine technologies, one possibility there, I'm speaking here, very hypothetically, is if we're able to manufacture vaccines more quickly, then we may be able to take a snapshot of what's going on, not at the beginning of the year, but maybe in the summer, or maybe, even closer to the flu season. And then our chances of matching the strains well are probably going to go up quite a bit. And I don't know, I guess I haven't quite directly answered your question, but that's sort of some of what goes into these considerations of strain selection, and again, evaluating after the fact how well you've done is a whole other ball of wax. Just one quick example that comes to my mind, back when we were looking at, we used to have, maybe we still have, trivalent influenza vaccine. So it has the two strains of A. There's A in influenza A and B. It only has one of the two what are called lineages of B. That's based on the sort of best guess of what's going to be circulating. We did some simulations. What's the effect of making it quadrivalent, putting in the other lineage also, which we now, I think, have, at least partly have, in most places. I don't remember Canada exactly. And we did some modeling there, and we basically realized, when you do these biomathematical models, whether or not you pick one or the other lineage and put it in there actually changes how the subsequent dynamics happen. So it becomes difficult to kind of think of a, what you might call counterfactual world in which you had picked the other lineage because, the dynamics have already been altered. Anyway, just another sort of example of why, these sorts of assessments are complex, but they should certainly be made with the maximum possible rigor.
Just really quick comment on that as well. I think it's also important to remember, we tend to remember the years where the flu vaccine was not such a great match, but most years it's very good. And actually, just looking at some data the other day, 70–80% efficacy. So, it's not a terrible vaccine. I think that we just hear those years and we go, whoa, how come we got it, we spent all this money, et cetera. The other thing is, though, by getting the vaccine, if you got the flu, if it wasn't a perfect, you still may get less of a severe flu. And so there's still value to it if the match isn't perfect. So there's a value to getting the flu vaccine. We don't know, and I mean, that's part of it is a bit of a, I'm not going to say guessing game, it's a predictive type of thing. But, the match generally the efficacy is generally very good, and that you do benefit from it even if the match is not perfect.
Can I just add very quickly? So the final thing to add, I agree with both of us we said, but the final thing to add is, I think looking to the future, we're hoping for flu vaccines that will be cover all, all strains will be a so-called universal flu vaccine. So that's where we want to get to, but it's a way off yet.
Okay, I was just going to say we have time for one more question. There's someone who's been patiently waiting up at the top there, so the brief question and brief answer.
Hello. My question is that I wanted to address it to everyone. We're taking the approach of trying to really prove that vaccines are good. As an up-and-coming scientist in the future, my concern is that are we researching enough, or do we have scientists that are researching the anti-vaccine movement, or why? Because science is based off of hypotheses sometimes. And is there anyone working towards disproving vaccines so we kind of catch the problems early and see the effects before it's too late and taking a proactive approach?
If I've understood you correctly, when you say disproving vaccines, do you mean in terms of the concerns of people who are vaccine hesitant specifically, or are you talking about vaccine safety? Or everything?
Vaccine safety and its effects,
Okay.
because yes, we're seeing the good effects, but we should, with the tools of bioinformatics, we can definitely look at, okay, this person has been vaccinated and they're technically the only scientific control for themselves.
Yeah.
What are the effects on this person?
Okay, that's a great question. I'm really glad you asked that, because I think one of the things we miss in the defensive reaction to anti-vaccine narrative is some of the little gems that are in there that are they're not little at all sometimes, but people say things and I think, okay, I don't think the information on vaccine safety is good enough. And I have a kind of split in my head, because part of me is actually we have tons of information to support the safety of our vaccines, but we could have so much more. So it's kind of we have really good data on safety, but exactly as you say, we should be able to identify exactly who was vaccinated, when, with which vaccine, and exactly what happens to them. All of that information. But we don't link all the data sets together yet. So I think that's where we should be going if we could only have the data in that form. But right now, getting the quality of information to do that exists only in a few places. Denmark is a good place. Manitoba has some good linked data sets. Ontario, we're not there yet. We can't do that to that level, but I think that's where we should be.
Okay, I think that's all we have time for. I'd love to continue this discussion, but I'd like to thank our panelists once again for fantastic presentations, wonderful conversation. So Heather McDougall, Nancy Wade, Edward Thomas, and Natasha Krokoff, thank you very much. Just a couple of points I'd like to make right at the end here. The great ideas that we have for these research talk series comes from you guys, from the campus community. So we'd love it if there is some interesting topic, something you feel we haven't covered in the past that we ought to, something that's in the news, something that concerns you, please let us know. Everyone who is registered for today, you'll receive an email looking for your feedback. So please do send us your ideas. We really depend on them. And then I'd just like to say, we hope to see you all here, maybe not this room, but hope to see you all come out on November the 21st for our next research talks on climate change resiliency. So thanks again to everyone for coming out today.